Welcome back. My name is Jason Levitas, and I'm a non-resident fellow here at Brookings. I also spend a lot of time providing technical assistance to state officials on healthcare issues on behalf of a Robert Wood Johnson funded project called State Health and Value Strategies. In my previous life, I led ACA implementation at the Treasury Department, and I'm very pleased to be with you all today. So in Mark's presentation and in the earlier panel, we heard a bit about the federal landscape and then what a selection of states have done in response and how that's worked out for them. This panel is going to take a step back and look at the bigger picture on the individual market and provide some more context and analysis. So to do that, I present you with some of the biggest and best thinkers on health insurance markets today. Each of them will give a short presentation. And then we'll try to reserve most of the time for discussion and for audience questions. So first you'll hear from Matt Fiedler. Matt is a fellow here at Brookings. His research covers a broad range of health policy issues, including a focus on health insurance market conditions. He is the former chief economist for the White House Council of Economic Advisors, where he led the agency's work on healthcare. Matt will delve more deeply here today into the federal policy landscape that states are facing, with analysis of how the different moving pieces may affect individual markets. Second, you'll hear from Sabrina Corlett. Sabrina is a research professor at the Georgetown University Center on Health Insurance Reforms. She's a leading expert on health insurance regulation and policy, and also regularly assists state officials in developing policy options. She will provide a broader look at how states have responded to the turbulent policy landscape. Third, you'll hear from Cynthia Cox, who directs the Kaiser Family Foundation's program for the study of health reform and private insurance, a name that I assume they took because the Center on Health Insurance Reform was already taken. Cynthia's research focuses on individual market conditions, including pricing, enrollment, and competition. She's also one of the lead developers of Kaiser's indispensable premium tracker tool, and she will provide more detail on individual market trends to date and what we know about 2019. Finally, you'll hear from Thomas Miller, a resident fellow at the American Enterprise Institute. Tom's research and analysis covers a broad range of health policy issues, including health insurance markets, the ACA coverage provisions, high-risk pools, Medicare, and healthcare cost growth. He will back cleanup and provide some deeper analysis, synthesizing what we've heard to try to develop a meaningful outlook for what's ahead. So after that, I'll get the discussion started with a couple of thoughts and questions, and then we'll leave plenty of time for discussion with you folks. So with no more ado, I will turn it over to Matt.
Thanks, Jason. So as Jason laid out, my charge is to talk about a little bit about the federal policy landscape. I think the Mark's opening presentation and the prior conversation has given a pretty good overview of what the major issues are. So I want to go deeper on an analytic issue related to one of these, and then flag one other issue that I think is flowing a little bit below the radar. So my first point is just about the impending disappearance of the individual mandate. I think there is a correct view that the disappearance of the individual mandate in 2019 is not going to be the end of the individual market. The presence of the subsidies means that the market will stabilize at premiums that are somewhat higher and enrollment that is meaningfully lower, but the market will find a new equilibrium. What I think is just important to keep in mind is that doesn't mean that the repeal of the individual mandate is not it's a quite important event. So I did some research released several weeks ago, just looking at the sharp decline in the uninsured rate that we saw among people with incomes above 400% of the poverty line as the ACA took effect from 2013 through 2016. These people weren't eligible for subsidies, and as you dig into the data, the most plausible explanation for why we saw an expansion in insurance coverage in this group is that the individual mandate was indeed shaping insurance enrollment decisions in an important way. If you sort of take that estimate of how effective the individual mandate was and you think about what does that imply for the population as a whole, you conclude that roughly 8 million additional people had health insurance in 2016 because of the mandate. And one would expect most of that effect over time, most or all, probably all of that effect to disappear over time once the mandate is gone. Other analysts have reached similar conclusions based on their synthesis of both the pre-ACA and post-ACA experience. CBO's revised estimates are that mandate repeal will reduce insurance coverage by 8 to 9 million people in the long run. And RAND's central estimate from an analysis they released in the last several days is that it will reduce the number of people with insurance coverage by 6.5 million people in the long run. So I think it's absolutely true that this is not existential for the individual market. It's also true that this is a fairly important event in our nation's health insurance system, and that meaningfully fewer people will have insurance coverage at the end of this. And my personal view is that for a variety of reasons, that's a bad and significant outcome. The other sort of less analytic point I want to flag is just one other policy change that I think has been a little bit below the radar to date, which is last year's the president's executive order included 3 policy directions. One was related to association health plans. One was related to short-term plans. We have sort of a good sense of where those are going. But the third was a direction for federal agencies to consider allowing employers to purchase individual market coverage for their employees via what are called health reimbursement arrangements. Because the individual market is community rated, large employers potentially have an incentive to shift some of their sicker workers, if they can, into the individual market because the community rated premium is substantially less than paying the claims costs of somebody who's very sick. Related, you could have situations where an employer, where their overall workforce is quite sick, it might be financially attractive for them to move people into the individual market in that way. Because of the size of the employer market, even if a relatively moderate amount of this type of activity occurs, it could have important impacts on the individual market. Whether or not this actually ends up coming to pass is going to depend in a substantial way on how the Trump administration goes forward with this policy, if it even does go forward with the policy, given that we haven't seen rules so far. But I think this is a sleeper issue that's worth watching as we think about how the individual market is likely to develop going forward.
Okay, thank you. So I'm going to just talk a little bit about how states have responded to, as Jason said, some of the turbulence that has been federal policymaking over the last 18 months or so. So there is some good news. Several states are really leaning in to try to shore up and protect their markets and their consumers from market instability, higher premiums, et cetera. And I'll just tick off a few examples. I would like to acknowledge the Commonwealth Fund, which supports the research that we do at Georgetown to track at a 50-state basis everything that's going on in state legislatures and at departments of insurance and with the state-based exchanges. Without them, we really would have a less vivid picture of what's going on. But I do want to acknowledge that with respect to, for example, the individual mandate that Matt just talked about, a few states have stepped up and enacted their own state versions of the individual mandate. These include DC, New Jersey, Vermont for 2020, and of course Massachusetts, which was the model for the ACA, which was enacted back in 2006, has its own state version of the individual mandate that will continue to go forward. With respect to these alternative coverage options that the administration has been promoting, like short-term plans and AHPs, similarly, we have seen a number of states step up and attempt to limit these as an attractive alternative to ACA coverage. Of course, there are states like Colorado, as Louise mentioned, that pre-ACA had limits on them as well. But some states that since the president's announcement in October are either in their legislatures are pushing for or have enacted limits include states like Illinois, Hawaii, Maryland, Vermont, and California's bill looks highly likely to pass. Of perhaps broader interest and appeal, as the prior panel discussed, is action on reinsurance. So we've seen a really interesting mix of very blue states as well as very red states pursue that option. So Oregon, Alaska, and Minnesota, of course, have implemented theirs. Pending before CMS include Maryland, New Jersey, Wisconsin, and Maine. I also think it's interesting. There's an interesting mini trend of states that currently operate on healthcare.gov or the federal marketplace platform that are pursuing a shift to a state-run platform that would give them potentially a lot more flexibility over the operation of their marketplace and be able to do things like extend open enrollment, support outreach and navigator programs more robustly. These include Nevada, New Mexico, and potentially Oregon. On the flip side, there are states that are embracing sort of a new environment at the federal level that encourages regulatory rollbacks of some of the ACA protections. So folks may already be familiar with Iowa's situation where they essentially exempted certain health plans, the Farm Bureau plans, from the insurance regulations. So they get a free pass from all the ACA consumer protections. But another state that's pursuing what they're calling state-based plans is the state of Idaho. We expect to see an announcement on that very soon. We've also seen North Dakota and North Carolina look at this as well. I think it's also important to be aware of the limits on states' capacity to really step in and fill the role that the federal government has played to date. So reinsurance may work for some states, but not for all. Some may lack the ability to generate the resources, the funding, the state match that is needed. Some may not have the built-in infrastructure that, for example, Minnesota or Alaska has. And then there are other options that are just really tough in terms of political capital that would need to be expended in order to get those policies through. So I'm hopeful that we will see more states lean in and step up to maintain and stabilize their markets, but I wouldn't underestimate the challenges that lie ahead. Thank you.
Well, at Kaiser Family Foundation, we've been looking at insurer financial reports over the last several years. And, when we're talking about ACA stabilization, I think one thing to keep in mind is that at least as of midway through this year in 2018, insurers in the individual market are really having their best year yet. They're performing better in 2018 than they have in any year since the ACA was implemented, and really probably since even a few years before the ACA was implemented. So that's on average. Of course, there are still some markets that are struggling. That could be local, rural areas or certain states where insurers on average are still losing money. But on the whole, I think the takeaway is that 2018 is shaping up to be a very positive year for insurers on the individual market. Part of that is that they overshot their 2018 premiums. When they were setting their 2018 premiums, it was in the midst of a lot of political and regulatory uncertainty last year, as you may remember. And so they guessed high, and now they are bringing in a lot of money. Looking ahead into 2019, given how profitable insurers in this market are right now, you would think that premiums for next year would be staying flat or maybe even dropping in some parts of the country. Instead, we're seeing premiums go up again. So we're tracking premiums in 2019 for states that have complete rate information that's transparent and available for the public. So it's only about a little over a dozen states. But what we're seeing so far is that silver plans and bronze plans are going up by about 12% next year, and gold plans are going up a little bit less by about 6%. But we're seeing, on average, high single to low double-digit rate increases for next year at a time when insurers are, by and large, profitable. And so the factors that are driving these rate increases for next year are, what Matt was describing. There's the individual mandate repeal, which is adding maybe 5 to 10 percentage points onto the premiums for next year. There's also the likely expansion of loosely regulated short-term plans that are likely to draw away healthy people from the ACA compliant market. And the people who are going to be paying these higher premium increases are the people who are off exchange, the people who are middle income or upper middle income, some of whom have already been priced out. We might start seeing more people getting priced out next year. The subsidized exchange market, on the other hand, is looking like it's going to still be strong in terms of enrollment, and there's more and more insurers who are entering into this market for next year. I think that's one of the really notable findings that we've seen looking ahead into next year. Mark Hall had a few examples of insurers. We've actually found over a dozen insurers entering into states, and again, we don't have information on a lot of states yet, but there's over a dozen new entrants or returning insurers into the market for 2019, onto the exchange markets, and we haven't seen any exits. That's a complete 180 from where we were this time last year. Last summer, we were looking at several dozens of counties that were at risk of having no insurance company because insurers were fleeing the market last year. And I think the insurers are starting to have a much more favorable outlook for the individual market, despite the kind of continued political or policy uncertainty that they face.
Thanks for the opportunity to both concur and dissent. Full disclosure and a caveat, for many years I served as the ranking minority member of the Right of Center Consensus Group. But I do want to offer my congratulations to Mark Hall and his researchers. I've learned a lot from Mark's work for many years. Some of the interesting points about taking some of the air out of the balloon of reinsurance. But particularly in this case, how insurers and many policymakers and defenders of the ancien regime still think and believe, whether or not very complex and mixed evidence, plus a lot of subjective speculation, actually turns out to be the case. The arranged shotgun marriage between the ACA's previous designers and implementers and private insurers has been disrupted, but the old flames still flicker out of mutual desperation, if not passion. On the other end of the spectrum, in health policy, as in many other policy areas, the movie script for the Trump administration appears to be "Our brand is crisis," as the 2016 campaign rewinds on a continuous loop. Now, the Trump version is getting bigger box office than the 2015 version. However, some of the reviews in international markets, particularly London, have been more mixed lately. Before getting to the partial disequilibrium model outlook for the individual insurance markets, let me suggest a few other reasons besides the de rigueur sabotage rationale for why there may be dissenters from the view that the greatest risks come from departing more recently from the original ACA architectural plans for the individual market. We've already had a lot of deviations from what was supposed to launch in 2014. Individual mandate and employer mandate enforcement, grandmothering, full service health exchanges, co-op insurance plans, risk protection funding, administration of risk adjustment formulas, and the list could continue. The original design was far from resilient, and it bowed in a number of places to political stress testing, adaptive mutation in the midst of environmental climate change. Another point is that stabilization is a relative term, subject to different perspectives and frames of reference, particularly since 2014. Many Republicans have been more concerned and aggrieved by the ACA-related destabilization of the non-subsidized individual market, both inside and outside the exchange-based coverage. Not everyone links the baseline for stabilization to the same times at which subsidies and regulations were changed. Third, development of the ACA individual market lacks sufficiently broad political buy-in. Now, certainly a wide cross-section of health policy theorists may have believed this stuff was going to work, and others were stuck with having voted for it or having to cope with it while running their businesses. But those who never got on the bus had little incentive to push it forward or keep it out of the ditch. Fourth, the worst case scenarios for the individual market either are not bad enough to scare and activate political majorities, or they just did not materialize, although they did provide polar opposite talking points and opportunities for blame shifting for either ends of the political and policy debates. So, regarding the future of the ACA and individual markets, the outlook, I used to quote Mr. T as Clubber Lang in Rocky III. When asked for a prediction about the fight ahead, I predict pain, and sometimes I pity the fool. But the outlook is actually more of a series of chronic conditions with dull aches, but far from life-threatening. Subsidies, higher prices, and deficit financing paper over a lot of affordability and operational problems, at least for the near term. And as we know in the long run, baby boomers believe we are not dead, we just go on Medicare indefinitely. I've written many articles suggesting the limited but targeted value of better subsidized high-risk pools, and I'd like to thank the ACA architects for moving closer to developing our largest ones yet. Yes, there has been too much overcharged rhetoric, fake threats, and government-created risk, but enough about the Obama administration. On the other hand, private insurers increasingly try to run away from and shed just about every kind of risk, leaving behind taxpayers to pick up things as default risk barriers. That's not going to stop until the flow of subsidies and regulatory protections slow. The ACA-shaped individual market cannot be killed or even put into a politically induced coma. It just slowed down to a much lower growth path, if not plateauing at a slightly lower level. As long as subsidies flow, someone is staying in business, just not in a particularly competitive market environment. Even if all the legs of the three-legged stool get chopped down or cut off, remember it's sitting on top of the subsidy cushion, which can also be used as a flotation device. One way or another, various probes to evade or escape some of the ACA's remaining edicts will continue because the latter insist on trying to force at least some insurers, providers, and consumers to commit unnatural acts against their perceived self-interest and values. So the parade goes on. Thank you.
Thank you to all our panelists. That was extremely enlightening and at times entertaining. So I'm going to just throw out a few thoughts, sort of pulling together what we heard here, as well as a bit what we heard on the earlier panel. Then I'm going to start with some questions for the panelists, and then we will take questions from you all. So I just want to sort of highlight some themes that we've heard throughout the day about what's going on and what may be ahead. One is certainly a lot of uncertainty and tumult and questions about what the landscape will be, but that's sort of bounded, as Tom was just pointing out, by the subsidy structure of the ACA and the structure more generally, that seems to be resilient, and that, you know, where the individual market may contract and it may have higher premiums, but it is likely to continue in some form and be useful at least to subsidize individuals. So a second theme we've heard again and again is divergence among the states going in different directions. And as part of that, and this is of particular interest to me in my work with states, there's just a huge amount going on at the state level in terms of where the action is on health policy. It is just difficult to keep up, notwithstanding all the great work by folks up here and on the earlier panel, with just all the different proposals, all the different legislative action that's going on at the state level, and it makes it sort of a fascinating time to study health policy and to be working with states. And I would just note one sort of piece of color on this is that of course this is all affected by electoral politics. And if you look at the two states that had their main state elections in 2017, those, of course, were New Jersey and Virginia. And in both of those states, you've seen sea changes in health policy, with Virginia expanding Medicaid and making a bunch of other changes, and New Jersey passing an individual mandate and reinsurance and making a bunch of other changes too. And it does sort of just make you a bit excited, like, wow, if those two elections led to all of that action, think of all the state elections that are coming this November and what next year might mean in terms of what we see out there. So keep watching the states. So with that, let me start with a couple of questions for our panelists, and then I'll turn it over to the audience. I guess one question would be, so this morning, the earlier panel was incredibly helpful, focusing on those 10 states and the 4 in particular, and hearing what's going on there. But of course, there are 40 other states and DC. Are there other particularly interesting stories that we should highlight, just have out there? That would be good to know about before we sort of delve more into analysis. Are there other states that you think would just be good stories for folks to hear about? Sabrina.
Yes. I think it as you say, it's kind of lots of divergence, lots of variance. I do think one thing that we're seeing that's very interesting playing out in state legislatures is there has been, particularly this past legislative session, a tremendous pressure on legislators to address the needs of the unsubsidized, the folks who really are facing these unaffordable premiums. And so that is, that we're seeing legislatures respond in different ways to that. But at the same time, we're seeing state level consumer advocates, patient advocates, insurance companies, and others sort of step up in coalition to sort of counteract some of those forces. So one example would be North Carolina, where there was a bill that was moving very quickly through the legislature to adopt a sort of Iowa-style Farm Bureau type of proposal. And what was interesting there was the coalition that really came up to try to kill that bill out of concern that, in fact, while it, there would be a number of folks with pre-existing conditions, particularly in the subsidized population, that would be harmed by that initiative. And they were successful. So I think there's, particularly on the advocacy side, there's been so much focus on Medicaid Advantage, on Medicaid expansion, that they've been a little slower to move to some of these private insurance issues, but they are starting to step up to the plate, and North Carolina is a great example of that.
Thank you. Any of our other panelists have sort of state highlights, specific stories you want to?
Yeah, I mean, this state just kind of came to mind when Alice was asking about rural areas in the last panel. I think that's really where the ACA individual market has struggled, is how to attract insurers into those markets. And when we were looking at bear counties or potential bear counties last year, it was almost always a rural county that was at risk of having no insurer. And so I don't know if any state has really come up with a good solution. I would be interested to hear more about what's happening in New Mexico, because that's one state where they haven't had that problem, and I don't know why it is. But on the other hand, Nevada had a kind of interesting strategy at first, which was to try to make it so that if an insurer wanted to participate in the Medicaid managed care market, they had to also offer on exchange. And so that was helpful in keeping the insurers in the exchange, but they all wanted to offer coverage in Las Vegas, not in the rural parts of the state. And then Nevada ended up being one of our states where almost the entire state was at risk of having no insurer, except for, right around the metro center. And so, I think that just sort of highlights how even states that are trying to address this issue, it's very hard to find a way to overcome it.
Great. Next question. So we have heard a lot about a set of actions that many states are taking between reinsurance and, in a few cases, state individual mandates, silver loading, potentially subsidizing above 400%. And that's, that seems to be sort of the normal game plan states are taking. Oh, and then, of course, with non-ACA compliant plans, on the one hand, some states are sort of trying to close them down, other states are embracing them. But that's sort of, so that's the game plan that seems to be out there right now. Do you all have thoughts on what other state policies might be coming down the road or should be coming down the road? What should states be thinking about? What might be the next big thing that states are doing if we were to have this discussion a year from now? Sabrina?
I have some thoughts. So one thing we haven't spent a ton of time talking about are the two pieces of litigation that are moving their way through the courts that could dramatically affect the individual market. One is a lawsuit in Texas brought by the Texas Attorney General. The Department of Justice recently provided a brief in that case suggesting that they would like to see the court strike down the pre-existing condition protections that are in the ACA, specifically the guaranteed issue and community rating protections. That's a situation where if the Department of Justice position prevails, a big chunk of the ACA that protects people will fall. There are some states that adopted the ACA consumer protections into their own state insurance codes, but it's a minority. So one thing that states could and should be looking at in the short term, if they care about this and want to protect people with pre-existing conditions, would be to sort of bake those protections into their insurance codes. The other new development, of course, is this New Mexico case where CMS has, in response, said that they would suspend risk adjustment transfers. And I won't get into the details of the case, except to say that it's perhaps raised some conversation at the state level about whether, particularly for state-based marketplace states, whether they should look at running their own risk adjustment program. And that's certainly something Massachusetts did when they enacted their own law in 2006, but then turned it over to the feds.
I would just point out that that risk adjustment is a good example of what was assumed and what turned out to be different. There were almost no state takers for risk adjustment, even though it's worked out in a very bizarre way with a lot of intended or unintended counter effects. The one area that I think I've been disappointed in not seeing any further movement on, now admittedly the very confused record of the Trump administration on waivers in itself tends to put a chill on getting more experimental or exotic. It's been sitting around for a while to basically overturn Obama administration guidance saying you couldn't basically pull off a 1332 mega waiver. It doesn't mean that they'll come up with anything innovative, but as long as you put a bigger pot of money together where you can slosh it around and pretend you're saving by mixing it across a wider base, there are ways to move what are subsidies in one place over to the other parts of the market, a bit of a mix and match way beyond the creative accounting of Arkansas. That would seem to be a missed opportunity for at least confusing more people about things and finding out whether we can truly reach bounded irrationality.
Thank you. And of course, folks probably heard that, a few months ago, there were rumors that there was indeed revised 1332 guidance coming out of the administration at some point, and we still haven't seen it, but that may be something on the horizon, revisiting some of those constraints that you're talking about.
I think the encouragement to sort of think of new solutions is valuable, but I also think, part of the reason there's a standard list that exists is because those are implementable actions that can tackle the problems. If your goal is to reduce premiums for unsubsidized people, you've sort of got we can do some things to improve the risk pool through individual mandate or changing enrollment, but your main problem here is that health insurance is expensive. So either you've got to find ways to substantially reduce the underlying cost of care, which is an issue that's much broader than the individual market, and is not, I think we should not wait to have our optimal healthcare delivery system to be the solution to this problem, or you're going to have to plow additional dollars into the individual market. You can do that through a reinsurance program. You can do that through subsidies above 400. They're all just different tools for achieving the same thing. And so I think new thinking is great. But I think we also need to understand that there probably are no magic solutions here either.
100% agree with Matt.
Great. Okay, one last question for me, and then we will take audience questions. So Cynthia provided sort of helpful information quantifying the state of the individual health insurance markets. And I want to get sort of into something a little bit more subjective here. Insurer decisions about where to participate and how to set rates has a strong non-quantitative element in terms of insurer optimism or pessimism for what's going on, sort of the atmospherics. And a lot has happened, obviously, to raise concerns, but again, there's also the growing feeling that the market overall is pretty durable.
given all that, what's sort of the mood of issuers out there? Are they feeling worried? Are they feeling hopeful? Are they feeling like they should get in to please certain regulators? Are they what's the state of mind out there in the insurance community given all that's going on?
Well, I guess I'll just say that I think this question of kind of the qualitative view of how insurers are thinking about the market is really important. I just kind of want to bring back up 2 points that I made earlier, which is that 2017 ended up being a profitable year for most, like on average, for insurers in the individual market. As you may recall, in 2017 was when insurers were fleeing the market. They weren't necessarily fleeing the market because they were losing money. They were fleeing the market in large part because they didn't know what the rules were going to be in the individual market. They didn't know if the individual mandate was still going to be in effect, whether cost-sharing subsidies were still going to get paid, whether the ACA was even going to exist or not. And so this fear that insurers may have that Congress or the administration isn't working to provide them with concrete answers about what the rules of the game are going to be is going to shape insurers' decisions about whether or not to participate in the market and whether they need to bake in an extra kind of cushion into their rates for next year. And just like one example of that for just this week was the question of whether the risk adjustment program those payments were still going to get made. And looking into 2019, in theory, those payments shouldn't be a question, but the administration didn't directly address 2019 at first. And we saw at least one insurer say that they were going to up their premiums relative to what they were going to be because they didn't know whether risk adjustment was going to be in effect in 2019.
Yeah, I would say if you had asked the same question 2 weeks ago, I would have said that there's an increasing sense that the market is going to stabilize, that they've weathered the worst of the storm. I think the decision on risk adjustment is so inexplicable from both a litigation and policy perspective. It's sort of reignited this tremendous lack of trust that insurers have that this administration is operating this program in good faith. And so I don't know what's going to happen over the next few weeks. There is a real timeline here. Rates need to be locked in the next, 6 to 8 weeks. Insurers have to sign contracts by the end of September. And of course, if you think back to last year, it was October when the cost-sharing reduction subsidies were cut off, causing all kinds of scrambling and revisions. So we're on a clock, and I'm sensing a shift a little bit in insurers' levels of confidence.
There's quite a market for anxiety in this space, ample supply and demand, somewhat induced. But from the perspective of insurers, what would be their political strategy? Everything's saying everything's fine, we can get through this. You want to always be aggrieved and besieged, and you'll have your defenders come there, and it also plays into the other side to say, this is great, we're really kind of causing a lot of trouble. Ultimately, there's certain boundaries on this. So if you can depress some of the fake theater and look at what tends to go on, I think we've had a bit of an overshoot in terms of anxiety. Also, you look in different markets where this, two different, if you have competing insurers, they may take different perspectives on this in terms of just the way in which they actually view what their rates are going to be. So shoot high and figure out where you end up afterwards.
It sounds like there's a World Cup flopping analogy at play here. Okay, well, thank you. That's really helpful. Let's open it up to the audience and get some questions.
Hi, Lynn Blewett. So I just want to add another strategy states are considering New Mexico and Minnesota, which was the public option buy-in. So buy-in either to Medicaid or the basic health plan, and actually offering a state option on the exchange. So that, depending again on the elections, that could be a viable strategy. And that's actually was considered for rural areas where there weren't very many options. And it could also be for the above 400%.
I would just respond to that there are cautions to consider with the public option. And Len, you made this point earlier about the basic health plan in Minnesota attracting enrollees away from who would otherwise be on the exchange market, and then you have a smaller market and fewer people to spread the risk over. And so it can also be maybe a disincentive for private insurers to go into rural areas if they know that there's going to be some other option there. I do think that in some cases we saw states kind of gently twisting arms of insurers to kind of go back into rural areas, and it ultimately worked.
One thing I'll just add on a public option. I mean, I think my suspicion is that public options are going to be tricky to make work at the state level, but I do think they're potentially interesting options at the federal level. But I think it's important to understand that the main thing many of these public options are bringing to the table are some variety of administered pricing. That's how they generate their savings. That private insurance rates tend to be far, far higher than the rates paid in Medicare, and particularly higher than the rates paid in Medicaid. And so the play here is you are able to introduce a lower cost option by having insurer in the market that has an ability to pay doctors and hospitals a lot less. In general, I think my view on the evidence is that the prices we're paying in the private insurance space to doctors and hospitals are well in excess of marginal cost, and so well in excess of the efficient level. And so that's likely a good thing, but that's fundamentally what these tools are doing for you.
Okay, I'm going to ask another question now because I don't see any hands. But while I'm asking this, I need you all to think. Oh, is there a question back there? Great. Perfect. But everyone else, think of questions.
Hi, Kevin Lind here. So Mark Hall's executive summary mentions other strategies like auto enrollment, assessments on non-compliant plans, and mid-year rate corrections for insurers. Could you comment on some of those other strategies that states could also implement?
So with respect to auto enrollment, I don't know if Tom wants to comment on that, because I know some of your colleagues at AEI.
They don't want me to comment on it. We'll just leave it at that.
Some of your colleagues at AEI have put out some very thoughtful pieces on this. I do think there are some. There are some administratively tricky elements to that, but it's certainly something a state could look at. I think one of the challenges particular to the individual market is it's a market with a lot of churn, with people transitioning on and off coverage throughout the year. You mentioned three things, and I know. Do you remember? That's the one of them was, I think, mid-year rate changes. Somebody over here needs to remind me. I thought those were prohibited, at least through regulation.
I think the context of this was if policy changes mid-year, allowing insurers to change their rates.
Oh,
like
okay.
if federal policy changes.
Federal policy changes. I'd have to go back and look at the regulations governing rate setting at the federal level. There may be limits on a state's ability to do that without a federal regulatory change. And I don't remember the third thing that you said. I'm sorry.
So I think the last one was taxes on non-compliant plans. I think you could think of this as basically a very sort of indirect way of expanding risk adjustment of a sort to apply to non-compliant plans. At the point where what you're trying to do is ensure that the differences in premiums between compliant and non-compliant plans don't reflect the different health risk of the two pools, I think there's frankly a more straightforward approach, which is just to have one pool and operate risk adjustment within it. So I think this is a somewhat indirect way of undoing the problem you created by allowing the short-term plans in the first place.
Alice
Rivlin. Every conversation about the Affordable Care Act is very, very complicated, including this one. The Affordable Care Act was trying to fill a niche problem. We had a lot of people covered by Medicare and by Medicaid and by employer-based insurance, but we had a bunch of people who weren't covered by anything, and the idea was subsidize them to buy insurance in the individual market from private companies. And it's turned out to be really hard. Should we give up and do something else?
I think this structure in a stable policy environment can basically work. I think we were headed on it. We saw in 2017 insurers could get the pricing right. And I think that would have led to, I mean, given that we're seeing entry even in this policy environment this year, I think we would have seen much more significant reentry over the subsequent years in a counterfactual world. Now, is this perfect? Absolutely not. And I think there are things we could do. I tend to think that introducing a public option in this market would be a good idea. I tend to think that larger subsidies would be a good idea. But I think this type of managed competition framework can function. Certainly, we've seen, while there are some important differences, we've seen a sort of managed competition type structure function in the Medicare Advantage program. So I think we have, plenty of reasons to believe, both in theory and practice, that this is a viable policy structure.
Yeah, I agree with Matt. I think the ACA is not perfect. There are certainly some things you could do to make it better, particularly around the affordability of the insurance. But I would hate to throw the baby out with the bathwater.
I think there's a lot to be said for giving up. I'm not sure about doing something else in terms of getting agreement. Most of our health policy involves trying to find a way to stick the cost somewhere else that no one else can see. We mostly had the individual market as the residue of that while taking care of everyone else. What happened within the individual market is we're not that generous to go ahead and subsidize everyone, so someone still had to get shafted for budget scoring reasons. And that tended to be people in the unsubsidized part of the individual market. Now, they didn't have the leverage to necessarily unravel everything, but that's what some are responding to through these various halfway measures. And you can push and you can pull and you can try to find money from somewhere else or shift it around, but ultimately not everybody goes home happy. And our health policy debate is basically trying to find the least objectionable parties being the ones who are unhappy.
Just one comment related to that. I think it is important to keep in mind, though, if we wanted, so Mark's proposal of, extend the 10% of income cap above 400% of poverty line, that is probably a order of magnitude $100 to $200 billion over a 10-year type of expenditure. That's a lot of money. That's not chump change, but that's also well within the range of the types of money one could imagine the federal government spending. So this is very much within the realm of achievable policy. I mean, certainly if you compare it to the amounts of money that have been moving around in recent tax legislation, it's chump change.
Could you comment on what exactly is going on with risk adjustment? And then will that have an impact on offerings in the market for this fall, both in terms of who shows up in the prices, or is it going to have an impact?
Oh, gosh. So just a little bit of context. Everybody's familiar with the risk adjustment program. It was one of 3 premium stabilization programs within the ACA. It's the only permanent one. It's used basically in a Medicare Advantage, Medicare Part D. A lot of states use it in their Medicaid programs when they have competing and Medicaid MCOs, but it's the idea of if you have more than average risk than your competitor has to give you money. So you receive money, your competitor pays money. It's sort of a rob Peter to pay Paul program. There's no taxpayer money at stake. The New Mexico Co-op, which was a small startup plan, sued over CMS's risk adjustment formula. And it gets very arcane very quickly, but essentially they felt like they were paying too much to essentially Blue Cross Blue Shield, which was on the receiving end, and they felt that the formula disadvantaged small startup plans. And that may be true. CMS has rejiggered the program over time, and it's not a perfect formula by any means. The court, when the New Mexico Co-op sued, the court agreed with the co-op in part, but disagreed in part. But one of the things they've said in their decision was, CMS, you have to provide a public rationale for why you chose the formula you did. We don't know necessarily if your formula was right or wrong. You just have to publish through a notice and comment rulemaking your reasoning. So there's some odd things about the way the DOJ, which was representing the government in that case, has pursued its litigation strategy. The most logical thing to do would have been to file an appeal and ask for a stay pending decision on that appeal. Instead, they filed a motion to reconsider with the district court. I'm not a litigator. I can't explain the thinking there. And then, of course, earlier this week, or I guess Saturday, they announced a decision that they would just suspend all payments under the risk adjustment program, not just in New Mexico, which would be one thing that they could do, but nationwide. This is a big deal. There are insurers like Blue Cross Blue Shield of Florida that are owed in excess of $660 million for 2017 alone. That's just one insurance company. Now, they may have huge reserves and it's no problem, no cash flow issue, but there's a little tiny co-op in Maine that's owed over $12 million. I don't know if they can hold out, how long they can hold out without that expected payment. So I hope that's... No, well, so the court's decision covered 14, 15, 16, and 17, and 18. In the most recent payment notice for 2019, the administration says that they've fixed the problem by providing a public rationale. Now, people say that's, that was in a final rule, so there's no notice and comment. So it's may not be on the most solid ground, but there is this question about 14 through 18.
Keep in mind, this is a process foul rather than a substance foul, and you've got other opinions and other court decisions, including in Massachusetts with Minuteman Health, which went in the opposite direction. Risk adjustment is a great concept and a great ambition. In this particular area, it's incredibly mixed. But I think this is another case of one of those, let's roll this one out and see if it scares a few people. But by the time we get into the fall, I think they'll back off from the brink on this. The fact that they put out the risk adjustment report with the numbers that insurers have to use to begin to do the calculations tells you there's a little bit of a mixed equivocation on this.
Yeah, but I would say, I think that if it were just CMS making the decisions here, I would have Tom's view that we should not worry. But the problem is, it's not just CMS making the decisions for the administration here.
Come on, we're supporting Theresa May this morning. I mean, it changes in 24 hours.
I think I saw the hand there in back first.
Hello, Carl Polzer. I'm a longtime health policy analyst, probably too long. So I read in this great report about overall cost increases being in the single digits, and I think this belies some more inquiry in a bit of sloppy thinking in the health policy community. It tends to rate itself on costs by looking back at itself instead of at the rest of the economy. A single digit cost increase, whether in the individual market or the whole of healthcare, can be 3 times the growth of the economy or 4 times inflation. And that's the biggest instability in the whole thing. We have just the cost of care can't be supported by the economy at the rate it's growing. And so the question is, if you're going to have a policy that's going to create universal coverage, don't you really need some kind of administrative pricing at some point to stabilize costs? And certainly building on the weakest part of the market, the individual market, to do the job is not enough. Just a question. Thanks.
So I don't have strong views, honestly, on what the right year-over-year change in overall health spending is. Over the very long run, we know that much of the reason that healthcare spending is larger than it was in the past is we have many more medical technologies. We know how to do many more things, and people are healthier for that. Now, I think it's absolutely true that there are some big inefficiencies in our system. And I think one of them is, particularly on the commercial insurance side, that the market power on the provider side means that prices are very high. I think there are also areas where we have substantial inefficient utilization. But I would think about it less as trying to reach a particular sort of target growth rate for healthcare spending, because I don't know what that is, and I think it's very possible that we should be spending a larger share of our GDP 20 years from now than we are today on healthcare. That said, I think there are plenty of things we can do, both on the provider pricing side and in terms of moving forward with various efforts on payment reform that aim to give providers stronger incentives to eliminate lower value utilization that we can and should be pursuing.
Carl, most of our public policy tries to have healthcare spending, despite what we say, go higher, and succeeds at that. The reason we have those public policies, we don't think people privately will spend enough. So until we change that political stance, there's always going to be someone paying the bill, even if it's disguised through multiple channels.
Okay, I think we have time for one or two more questions, and then I have a final question to wrap it up. Yes. Oh, sorry. There are people out there helping choose the questions. Go ahead.
Hi. Do you think that the rules regarding the guaranteed issue are here to stay, or how serious is the threat in light of the Texas lawsuit and actions of the administration? And what would the insurance landscape look like in states that don't have pre-existing conditions written into their healthcare code if those rules were repealed?
I mean, it's hard to say. When you're dealing with the federal courts, it can be a little bit of a crapshoot. The Texas Attorney General forum shopped for this particular district judge in Texas, who's known to be pretty antagonistic to the ACA. So it's potentially likely that they'll get the judge ruling in their favor. So this could work its way through the courts for a long, long time. There is California led a group of AGs to intervene on the argument that the federal government was not going to defend their interests. There's an interesting wrinkle there where the Texas AG has said that if the court agrees with the Department of Justice opinion, he should just enjoin the ACA in the plaintiff states, so the red states, which could mean that the pre-existing condition protections would only fall in those states, which is, I think, 20 states. But for states like California, New York, other states that are not plaintiffs to the case, it would be status quo. We don't know what the court's going to decide. So,
I think it's a great prank case because basically they took the arguments that first Roberts did in terms of justifying the individual mandate, and then took the brief from the Solicitor General in terms of what was defending. Well, in the event of the individual mandate goes, it's because this is so tightly wound together, we've got to get rid of guaranteed issue and community rating. Now, is a higher court going to actually swallow this? No, they'll come up with a new rationale if it comes up from the district court. But in the meantime, I think the more narrow conspiracy view is they might try a settlement before a full decision in the case and slow down the ability to appeal this for some period of time, let alone its application only in the states that wanted it. And that could slow down what goes up to a higher court.
I will say, I mean, if you read some of the legal commentary on this, on the logic behind the case that has been filed in the Texas court, it really does not hang together. And you've got people, including people who are behind many of the prior legal challenges to the ACA, saying this case simply does not make any sense. I think Sabrina's point on this is a very carefully selected judge is an important one, but at least I would hope that the courts still have the ability to sort of look past the particular type of sophistry that's reflected in this argument.
Okay, well, I want to ask one last question, and then we do need to wrap up. So we have spoken a lot about the administration actions. We've spoken a lot about state actions. We have not spoken very much about Congress. And obviously, Congress tried to do a variety of things last year, first repeal and replace, and then various stabilization measures, and nothing was able to pass. And, we've seen little bits. There was just this markup for some HSA-related legislation. Is there anything helpful to say about, what are we likely to see out of Congress, if anything? Are we just going to be in status quo over the next, however long until there's a new Congress or a new president? Or is there anything that might be an area for consensus might be an area for compromise in Congress.
You're searching for trace elements.
Nothing before the midterms.
Right. I think after the midterms, if Republicans hold the House and pick up a couple seats in the Senate, my expectation is that we would see another effort at passing more comprehensive ACA repeal legislation. That's my guess. I think short of that, it's likely to be stasis. I think the truth is, this is not primarily about the two parties squabbling. This is primarily about the two parties have sort of fundamentally different objectives, policy objectives, and visions for where the country should go with respect to healthcare. And I think those disagreements are going to be very difficult to bridge.
And the harder Congress tried to repeal the ACA, the more popular the law got.
Well, great. Thank you very much. Let's give a round of applause to our panelists. Thank you. Thank you for being a wonderful audience. I do have two closing notes. Number one, if you could just grab your coffee cups and other belongings, that would be great. And number two, copies of Mark's report are available on the registration table outside. So feel free to pick one up. Thank you for coming.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.